4, 3.
Good afternoon, everybody, and welcome to this meeting of Bristol's Health and Wellbeing Board. Apologies if you were waiting for the meeting to start. We've had a little bit of technical difficulty, but it's nice to see everybody. So welcome to all. And I'm going to ask the participants in the meeting just to introduce themselves. And we always get this where the screen jumps around, don't we? But let's have a go. See if we can do it with seamlessly. So, Mark, you're first on my screen.
Hi everyone, Mark Allen. I'm in the Public Health team and Support Officer for the Health and Wellbeing Board.
And Tim?
Hi, I'm Tim Poole. I'm the Chief Executive of the Carer Support Centre, supporting unpaid carers.
Thank you. Sally?
Hello, I'm Sally Hogg. I'm a consultant in public health, responsible officer for the Health and Wellbeing Board.
And Asha?
Hi everyone, I'm Councillor Asha Craig. I'm Vice Chair of the Board and I'm the Cabinet Lead for Public Health.
And Christina?
Hello, Christina Gray, Director for Communities and Public Health.
And Alison?
Hello, I'm Alison Bolam. I'm a GP in Bristol and I work at the CCG and I am co-chair of the Health and Wellbeing Board. Helen.
Hi, Alison. Dave Jarrett?
Good afternoon, everyone. I'm David Jarrett. I'm the Area Director for Bristol at the CCG.
Hugh?
Good afternoon, everyone. I am Hugh Evans, and having just said goodbye to Jackie Jensen for the final time, I am the interim Executive Director for People for Bristol City Council for 12 months.
Thanks, Hugh. And just if any of you are confused, because we said cheerio to Jackie, didn't we, at the last Health and Wellbeing Board that we had. That was the last time she came here, but we seem to have had quite a few chances in meetings to say goodbye to her this week, which has been lovely to note her contribution to the city and the City Council. But and welcome, Hugh, in your new role. Hey, you're next.
Hello, congratulations, Hugh, and good afternoon, everyone. My name is Kay Libby. I'm Chief Executive of Age UK Bristol.
Elaine?
Hi everyone, I'm Elaine Flint. I sit on the Health and Wellbeing Board as the voluntary sector representative. I'm co-director of Wellspring Settlement.
Raquel?
Hi everyone, I'm Raquel and I'm here to represent the City Office team.
Janet?
Hi everyone, I'm Janet Rice, Chief Executive of Serona.
And Carly?
Hello everybody, my name is Carly Urbanski and I am the head of the Bristol Aging Better program.
You're a bit faint, Carly, so when you do your bit later, make sure that you've got your volume up. Zara?
Good afternoon, everybody. My name is Zahra Kassar. I am one of the commissioners of the Commission of Race Equality, CORE in short. I also work for Bristol Somali Resource Centre as a mental health coordinator, but today I'm representing CORE. Oh, thank you.
Thank you. Tim Keane.
Hi, I'm Tim Keane, Associate Director of Strategy at North Bristol Trust, and I'm here today on behalf of Evelyn Barker, our Chief Executive.
And Jamie.
I think Jamie Eilert Jones has been brought in a little bit in advance of his item. He's actually speaking as a public participant.
Oh, yes, yes, of course. Well, we'll be on to that in a minute then, Jamie. So, Jerry, got any apologies?
Yes, we've got a few apologies, Chair. Evelyn Barker, and you just heard that Tim Keane is substituting for her, Julia Ross and Cathy Capel.
Great, thank you very much. We've noted those. Are there any declarations of interest from any of the members present? No? We've got the minutes of the last formal meeting, which was the one on the 27th of January. Are you happy to agree those as a... Thanks, Carly, for your comment in the chat. and we'll hear more from you later. Are you happy to agree those minutes as a true record of that last meeting? Any comments on those minutes? No? Great. So now we're on to public forum. So Jamie, do come in and join us.
He's already here, Chair.
Already here, great, good.
I think may have some supplementary questions to ask to
yeah, okay.
He's asked.
Great. So has everybody seen Jamie's questions and the formal responses? They refer to plant-based food on the menus at schools. So Jamie, you've got your formal answers, but you've got the chance to be able to ask a supplementary on each of those if you wish to.
Yes, please. Yeah, the supplementary question won't make too much sense out of context for those who haven't seen the replies, but
I think everybody has seen the replies, or certainly they've had the opportunity to see them because they have been circulated.
They were circulated yesterday, Chair.
Okay, that's no worries. Yeah, my supplementary question for the first one is, thank you for the response. First of all, I have many questions I'd like to ask in reply, but I'm aware that this forum only allows me to ask one. So in this case,
just to clarify, Chair, one question per formal question.
Yeah. So my first supplementary question is, who can I talk to further discuss this matter, specifically in the local authority? And could I request a meeting with this person, please, is my question.
Well, the answer refers to some of the food strategies that we've got going on, certainly going for gold and so on. I don't know, Asha, if you want to, as the person with political responsibility for that, or Sally, because of the work that you're doing, do you just want to flag anything up quickly to Jamie, and then obviously there can be future meetings or correspondence?
So Jamie, we're in the process of developing a food equality strategy, and we also have a whole system approach to healthy weight within the city. And a healthy weight declaration was signed almost exactly a year ago by the mayor, by the cabinet members that are responsible. And we've got, we feel, a very good rounded approach to both healthy weight and food equality, food poverty, and all the things around the going for gold, which I'm sure you have heard of and know about sustainable food products, about waste, about growing, and our aim is that we make our city as sustainable and as green as possible. We're very happy to talk to you if you'd like to. I'll put my email address in the chat, and you can get in contact.
Have you got any supplementary on your second one?
I do. It's very similar though. It is basically just saying also thanks for the response, and I have a lot more things I'd like to query and question and discuss. So if there's someone else that this kind of falls in their realm, I'd really like to get in contact. And
I mean, certainly get involved with the consultation on the food equality strategy, because that's going through, as Sally's mentioned. Perhaps I'm being a little bit facetious, but when I saw in your question that you referred to food at council events, I was kind of thinking if only, because I think we were all very much waiting to get back to meeting in person, although over the last few years, because of austerity, there's been very little food supplied at council events. But Asha, go on, you want to say something as well?
Yeah, I was just going, that did make me laugh actually, because I thought, when was the last time we provided any food? So yeah, but no, to more seriously, I think if you have any questions for us, Sally's just put her contact details because she's driving the work around food equality strategy. We're actually about to submit our bid to become a sustainable food city. But the work that we do on the strategy will really set out a whole system approach to how we tackle food equality and food insecurity in this city, and that also includes what we eat, what we grow, how we produce food, and how we procure and how we deal with our waste. So I'm happy for you to kind of engage, send through your questions, and we'll respond and find ways for you to engage in this work. Thanks.
Thank you. Yeah, I'll get in touch with you, Sally. Thanks for providing your email and the response. Asha, Craig, thanks.
Unmute myself. Sorry, thank you very much for your questions, Jamie, and it's quite exciting for us to get to public forum on the Health and Wellbeing Board, because we don't very often do it, although we do in a lot of other council functions. So thank you for taking an interest in our work. Just before I go on to the next item on the formal agenda, if everybody's happy, just for me just to give you a bit of an update, because you will be aware that this morning there was some coverage of the what's become a national issue about the do not resuscitate and learning difficulty and disability deaths. And I just wanted to reassure, we already have done, because some questions came in to me when this was raised, I think in the Observer about 3 or 4 weeks ago, and I had some questions from members on the back of that and was able to satisfy myself about the situation in both in Bristol and in the CCG. But some of you may have seen, if you get the correspondence from the CCG, but Julia Ross has sent out today that BNSSG took part in the review that the CQC has launched, the report that they've launched today. And just if I can read just part of it, because I want that reassurance to be out there for people. So the feedback we received, that's the CCG, following the review process was overwhelmingly positive, reflecting the fact that respect has long been established across our system as standard practice. Reviewers praised the strong stance taken in relation to DNA CPR at the system level, particularly the clear statement that DNA CPR should never be applied as a blanket policy. And we were particularly pleased to hear from the CQC's reviewers that health and care staff in BNSSG demonstrated a strong commitment to supporting the most vulnerable. And we were heartened that staff felt supported and understood the process for raising concerns. In my earlier answer that I got when I asked questions about this when it originally came up, there were the numbers, and I think that I mean, obviously, sadly, there have been deaths of people with learning disabilities in Bristol and in the CCG area in the last year, COVID deaths, but these were not exceptional, and certainly when those cases were reviewed, none of them had do not resuscitate notices on them. So I hope that that gives reassurance. And if people want the wording that Julia has sent out, I'm very happy to send that to Jeremy and he can send it to members of the board so that you've all seen that if you haven't had it. But I just wanted to use this opportunity as that information came out this morning, just to share that with you all as partners. So I hope that that is of some use. So now we will go back to the formal agenda, and the next thing is the forward plan. So over to you, please, Mark.
Yes, so the 1st of April, we have a joint meeting of the BNSSG Health and Wellbeing Boards, where we'll be looking at the Health and Social Care White Paper, amongst other things. Then on the 22nd of April is our next development session, where we'll be updating our plan on a page and also working on the One City Plan action around community mental health. And then our next formal board, the provisional date of 26th of May. And we have a few items that we're working on for that, including an update on the Joint Strategic Needs Assessment. Thank you.
Great, thanks, Mark. I mean, it's always a slight hiatus. Obviously, Bristol has elections, South Gloucester and North Somerset don't, but normal service hopefully will be resumed as soon as possible, but we don't know who will be in the chairs at the time. Christina, your turn now. So an update, please, on our COVID situation.
Thank you, Helen. Good afternoon, everyone. So I'll just give you a quick overview on our rates and numbers to date, and then just cover off a few of the key issues that have been in the news around new variants of concern and the AstraZeneca vaccine. So very good news in that our background rate of infection is now below 50. So as of yesterday evening, it was 46 per 100,000 and still going down. The rate of reduction is slowing. So we do need to keep the pace on that downward trend. Just to keep reminding everybody that when Leicester City went into its lockdown last March, its rates were in the 30s. Yeah, so we've got very normalized to this very high background rate of infection. So going in the right direction, but we need to be driving this down. We need to be in single digits, really, to be able to manage and prevent infection with test, trace and isolate effectively. So we've still got a way to go. The R number across the southwest is below 1 now, so between 0.5 and 0.8. So definitely got a reducing trend across the whole system. The positivity rate has reduced incredibly since our last meeting. I was just checking, looking at the minutes, and the last time we met, the positivity rate was around 10%. It's now 1.8%. So that's really excellent news. And what that tells us is that the background rate of infection is reducing. Still doing a good number of tests, around 10,000 tests, but those are a mix now of the PCR tests, the symptomatic tests, and the increasing number of lateral flow rapid tests, which have been rolled out. So the number of tests reflects all of those that are registered on the system. The positives include positives from both lateral flow and PCR tests. The vaccine rollout still going very well across the system and across Bristol. About 30% of the whole population, the whole eligible 16 plus eligible population has been vaccinated, which is quite extraordinary. We do have some work to do in Bristol because the take-up is considerably lower in some wards and in some communities, and we're just starting to get that data through. We've been doing a lot of work with pop-up and outreach clinics, working with the vaccine group, led by Carol Slater and Mohammed Al-Sharif, working with our faith communities and our place-based communities. But we do need to do much more. And we now have the granular data to be able to show us where we need to focus, and we will be doing that. So I just want to say a little bit about AstraZeneca, which has been in the news. The UK MHRA, the medical health regulator, has been very clear and has issued a statement that the benefits of the vaccine in preventing COVID-19 with the associated risk of hospitalisation and death from the disease itself far outweigh the risks of any side effects, and encouraging people to go and get their COVID-19 vaccine when asked to do so. And there is a statement up on the website which will circulate with the minutes. This is to do with an association of reported blood clotting incidents. But in Britain, in the UK, the number of those incidents is in fact lower than you would expect in the general population. So there is no causal effect or concern that has been identified in the UK, and the biggest risk is that this news impacts on vaccine confidence. So as I say, the MHRA are heading up the statement. We'll make sure that you've all got that and can look at it in some detail. The other thing that's been in the news since yesterday is an issue about the supply pipeline for the vaccine. Now, what this in effect means is that during April, the system has been asked to complete second vaccinations and to complete the vaccinations in the phase 1. Phase 1 are cohorts 1 to 9. That's everybody over 50, plus those working in frontline health and social care, plus those who are clinically vulnerable. So quite a large group of people. Those priority groups, 1 to 9, once vaccinated, will account for 99% of all those who are most clinically vulnerable, the highest level of risk. So that's the protect side of the equation. So the focus, and there is sufficient vaccine to continue to do that throughout March and April. What is being paused or put into the pipeline from May are all those in phase 2. That's the under 50s who don't fall in any of those other groups. This isn't going to impact on the final ambition of getting everybody offered a vaccine by July. That won't change. But what is being reported is the management of the vaccine supply, and therefore, instead of just pushing down into that cohort 2, they're going to make sure that the cohorts 1 to 9, the phase 1, is completed and fully completed before moving on to the next phase. And that's particularly important with the second vaccines, obviously, and there is sufficient vaccine to manage that. So all of that is on our bi-weekly report. We've got a summary of all of those pieces of information, but I thought they were particularly relevant today. Variants of concern, again, looking at the minutes, my goodness, a couple of months is a long time in COVID, isn't it? So we hadn't had our variants of concern, and we hadn't undertaken our surge testing when we had our first Health and Wellbeing Board. Again, we've got a little summary on the bi-weekly report, but suffice to say that living with, observing, identifying and containing new variants is going to be what we nationally and with the global health community are going to need to do, particularly over the next year or two. It is in the nature of viruses to change and adapt. Viruses do this all the time. We're very familiar with the flu virus doing this, and the big pharma companies adapt the flu vaccine every year to try and have the best fit to the strain of flu which is circulating at any one time. So our virologists, our pharmaceutical companies do understand this process, but what's important, because this is a new virus, is that they are able to observe it closely and have sufficient data in order to make sure that the vaccine stays ahead of the virus. So the mass testing, which we have been participating in and which has been happening across every region of the UK, has been for two purposes. One, to make sure that every case is identified and contained, so we stop chains of transmission, most important thing. And secondly, to gather data to support the scientific community to stay ahead of the virus. New variants, there's now a very good report, a national report, which is on the .gov website. And again, it's on our bi-weekly report. The link is on there on the bi-weekly report, but we'll circulate it with the minutes. And that shows you the total number for each of the new variants of concern which are in the country. So to put it in context, for the two variants that we've had locally, the Bristol South Gloucestershire surge and then the South Gloucestershire P1 variant surge, In the country, there are about 35 of the variant that we were looking for across South Gloucestershire and Bristol, so that's in the country. And for the P1 variant, I think there are about 10 in the entire country. So we're talking about very small numbers, very intensive work to hunt these new variants of concern down and contain the spread. So as I say, do look at our bi-weekly report because all the links and further information are on there for you. Thank you.
Thanks very much indeed, Christina. And I'm sure I'm not alone on the Health and Wellbeing Board of you being more regular now on Points West than David Garston is. But I think that, you know, the way that you have been able to very calmly and very logically convey the message to the wider public has been really exemplary. So thank you very much for that. Just a quick question from me, and then I've got David Jarrett has got his hand up as well, is that obviously we said that one of our priorities was going to be around rollout of vaccination to make sure that disadvantaged communities or communities of geography or of interest in the city weren't missing out. And some of those very big numbers can mask some areas of concern, and obviously we're not going to do it this afternoon, but I think that at some stage that the board will want to take a bit more of an even deeper dive into that to make sure that we are reaching everybody, especially the most vulnerable people. And you will know that Helen Godwin and I particularly asked about reaching homeless people, for example. So
yeah.
some good work is happening in other authorities on that.
Thanks, Helen. And I have to say our work has been exemplary. So we'll get Carol Slater and Mohammed El Sharif who are leading our work. And indeed, the work with the homelessness, our homelessness and complex needs community has been stood up since last March. So you'll be aware in Bristol, enormous networks of voluntary effort and support alongside our homeless communities, and we've got 2 dedicated public health colleagues who work with that group, and Serona, Janet have been absolutely marvellous in that space as well, with the Haven and the specialist services. So it's been a real joint effort, but I think it would be very good to have that report here. It's certainly been a high priority for the local engagement board as well, so there have been regular reports go there. We've only recently had the granular data for Bristol, so we've had within Bristol data, we've only just started to see that, so it'd be good to bring that. Thank you.
Thanks. So I've got 3 people with questions, and then we'll have to move on because I don't want to keep visitors waiting. But so it's David, Asha and Janet.
Hi, thank you, Christina, and some really encouraging figures there. My question's around testing. Do the figures that you've given this afternoon include school test results?
They include lateral flow rapid tests where that result has been put onto the system, but not all negative results from lateral flow get put onto the system. All positive results from lateral flow get put onto the system. So we can absolutely see the number of positives that we're getting from all sources. Those numbers, Dave, don't include what's called Pillar 1 testing results always, but they do include all Pillar 2.
Okay.
Asha?
Oh, hi. Yeah, Christina.
Oh, we've lost you. Asha, we can't hear you.
When is the public going to have the results of that surge testing, because they remain concerned, what's the percentage, how bad is it? They feel like I did have to remind them it's not the city councils. we're not responsible for that piece of work, but yeah, at some point we need to inform the public.
So I think Asha's question there, sorry, we lost you, Asha, for...
oh, sorry, yeah, my question, oh, sorry, somebody tried to bring me. My question is, are we going to be in a position to let the public, wider public, know about the impact of the surge testing and the variants?
Yes, so I can give you the overview for the Bristol South Gloucestershire. So we conducted over 40,000 additional asymptomatic tests, PCR tests. 1% of those compared to about 3% of symptomatic tests were positive. So the first thing to note is that indicates we're not sitting on a large pool of background rate of infection that we didn't know about. So that's reassuring. Mm. All of those positive tests have been followed up, isolated and contained. So chains of infection have been prevented. We have, along with other areas of the country, we have not had 100% of the genomic sequencing back from those 2 weeks. We've had back about between 15 and 20%, we think. And there have been 2 additional cases that have been identified by that route. These are historic cases, so they're not live cases, and they're part of that 35 in the country that I spoke about. And by far, the most effective way of finding cases was traditional public health contact tracing and enhanced contact tracing inquiry. That's where the majority of those 35 cases have been identified, not the surge testing. So the surge testing to date that's come back, we haven't had all of it back, but we've only had 2 additional. So that, again, that indicates to me that we're sitting within that, within the country, that low number within the country, that again, we're not sitting on a very large problem with that particular variant locally.
Thank you.
And Janet.
Thank you. Christina, I just wondered, with regard to AstraZeneca, whether there was any data or whether it's too soon yet to see whether that is having an impact on people's uptake locally, and if so, whether there's anything more you need from system partners?
Thanks. I think everybody is extremely worried about it because we know that whenever there's a doubt about the vaccine, it impacts. So there is a great deal of concern, and I think that's why the MHRA have gone out very strongly. So the ask of system partners is to get the communication pack from the MHRA, or it will be circulated by the NHS in the NHS bundles, I'm sure, Janet, and just to be reassuring people and helping all staff to have the data at their fingertips, to understand what the story is and why it is that this is safe.
Thank you.
Thanks very much indeed, Christina. And I know we're running a little bit late, but I do think having the detail of the report and being able to question it is really useful. And we'll carry on doing that for some time yet. David.
Thank you. I'm David Weinick. I'm talking later, so I've just dialed in early. Just in relation to the AstraZeneca vaccine, there is a new paper that has just come out. There will be a press release from MBT on it. It's probably just gone live now, showing that in patients who have long COVID, there are no difference in any side effects with either of the 2 vaccines being used in the UK.
Sorry, switch myself off instead of on then. Just as we've mentioned the priority that we've got for vaccination take-up, we forgot to mention at the beginning of the meeting our great victory in the city gathering last Friday, where we put forward the Health and Wellbeing Board's priority of priorities, which you'll remember we chose at the stakeholder event back in February, which was around mental health and particularly around engaging with communities and community assets to deliver better mental health outcomes. And that was chosen by the city gathering as the overall priority for this year. So that was pat on the back for everybody, and particularly those people who are involved in that work. So I'm now going to go on to the first substantive report, really, which is agenda item 8, which is about the age-friendly city. So Carly, come on in, and hopefully we can hear you really well now this time. But you're very welcome, and go for it.
Okay, great. Thank you so much. Can everybody hear me or no?
A little bit, if you could speak up a bit.
Sorry, I'm not sure what's going on with my mic, but if you...
That's much better.
Okay. If it happens again, Kay's here for some backup, so she can take over. I'm just going to quick share my screen with you, so I'll make sure that works. Can everybody see that? Okay.
Yep.
Perfect. So again, I'm here representing Bristol Aging Better today, and I know a lot of you already know the program well, so I won't go into too much detail about it all right now. But we just wanted to remind everybody really the key aims of the program and why it's so important that we're here today at the point that we are in the program. One of our biggest aims was obviously to tackle isolation and loneliness across the city for over 50s. And we've been doing that for the past 6 years. But one of the key reasons we're here today is because, apart from also having one of the big aims of establishing an evidence base to share across Bristol, we are now at a key turning point because we had partnered up with UWI. We had a team there working across the BAB program, across the city, to do all of our evaluations. And we have so much of that evidence base now complete, so we're able to really demonstrate the impact that the BAB program had to date. And we now are at a point where we have a full year left, and we really want to work across the city to make sure that we embed that learning. And again, that's why it's great that we're able to be here today to speak to you about that and just how we can take that forward and how the board can be a part of this as well. So the original bid actually sat within adult social care. So we are they've been a key partner of ours across the whole program. Carol Watson and Sonia Davies sat on our board the whole of the BAB program, which was great. And that's now turned into an even stronger partnership. And we have been working on supporting them with their new early intervention and prevention strategy. And that's been ideal, an exact example of how we're trying to work going forward in the next year. And AGK Bristol was also a massive part of the BAB program throughout the entirety of the program. And that's why Kay Libby is here with me today, because they were the host organization of BAB. So they really understand the BAB program, the emphasis that we have around the age-friendly city work and this whole system approach going forward in the city. And they will be key when the core BAB team are no longer funded anymore, because they understand that age-friendly work. So them being a key partner and player in this world, but also alongside people like Bristol People's Forum as well, and public health team and the council, and working with other partners as well. So that's why Kay is here as well, to be included in the discussion. So one of the strengths of the BAB program has always been that we had a core team sitting in AGK Bristol, but that we were not the sole providers of the actual services across the city. One of the strengths that we now have evidence to back is that we were running this across the city with 30 different partners, because that's where the skills and the expertise were in the city. And it was great that we could work across the city with multiple organizations, but that we also had the time and the space through our dedicated team to be able to work with wider partners and across sectors and in a more strategic way as well. So it's given us an opportunity to work with the Bristol Health Partners and with Sirona, the CCG, and be able to kind of have those conversations and now be able to, at this point, embed the learning and look at how all of this fits together. And just lastly, one of the key strengths of the BAB program is that we have always had older people at the heart of the program. It has truly been a co-produced program, from being a part of the original bid and the design to the delivery, being a part of all of the application process, interviews, where funding actually went into the city, to also being the actual evaluators themselves. So it's been great that we've been able to also demonstrate how that really is important and has a big impact for services across the city. So for those of you who know BAB, you'll have seen these squares before, but again, we just wanted to bring this into the conversation today because it just demonstrates how we really did work across sectors and with this whole system approach throughout the entirety of BAB. And that was one of the key strengths that, again, now through our evaluators at UE, we've been able to demonstrate that having all the pieces of the puzzle working together at the same time was really one of the strengths and what made us be able to succeed in doing what we were doing. And that's why we're recommending this going forward, because we were always working with, you know, social prescribing services, as well as having community development programs running. And all of these meant that older people actually benefited because they could move through the system and work with different people. But we were also be able to bring all the delivery partners together. And that was a strength to be able to share and be able to look at where there were gaps in the city and work together to make sure there was no duplication happening as well. And again, what underpinned all of this was age-friendly city work, because everything that we were doing was always working to make sure that the city was working to be more age-friendly. And as you'll see here, we are really pleased to be able to say that we can demonstrate that the BAB program had a true impact on decreasing the loneliness and isolation of the participants and increasing the health and well-being. And this was based on around 3,000 participants who completed the quite lengthy questionnaires, but it gave us great data and a base to show what we were able to achieve in the city. And again, we know some of the strengths of each of the projects individually, but we now know how much of this was because we ran all at the same time across sectors, working with multiple organizations in that whole system approach. So last quick table on our findings. And as you can see, we have our outcome measures, and all of the green boxes are where we had statistically significant results in actually helping the older people in the city. And again, with our evaluators, we now know how much of that was because we were able to do this at the same time and run the projects and have people kind of run through, you know, breaking down their barriers, their health barriers, mental health, physical health, and be able to access different systems and different projects and groups and activities as they needed to. So that brings us to why we're here today. And I know we'll have a further discussion about it at the end of the presentation, but we know now from our evaluations how key the BAB program was in making all of this happen. And that's why we're asking of the board, as such a key part of the city, to be able to have oversight of an age-friendly work plan. Bristol Aging Better has a full year left where we have capacity to work on this, to support, to help where we can, with myself as the head of program, but also an age-friendly officer who is dedicated to this work. And we know that us being able to champion and host this in the past was a key strength, but we also know that we only have a year left and we want somebody to take this forward where we can have a year to have an overlap and support this. And we feel that it would be great that the board yourselves are able to help us with this and also help us across all of the different thematic boards. We know that a lot of the Bristol Aging Better work comes under each of the boards because we've had such a wide range of services that we provided and topics of learning that we were able to delve into in our 6 years. So we have a lot of the knowledge and the backing to be able to work across the boards. And that's why we're also asking that we have the support to be able to work across the boards and to help set targets with the One City plan. Because again, we have this year to be able to support to do that. And I know I already actually have a meeting set up with Andrea Dell in a few weeks. So to start that kind of ball rolling, but it'd be great to have the board's support as well. And just to reiterate, we know now how much this had an impact on older people in the city, and we know the importance of having the sustainability, the co-production element, older people at the heart of what is going on in the city, and BAB has been able to do that. So we have still the learning, we have access to older people, to their opinions, to what's going on. We work very closely with Bristol to People's Forum and are also actually starting to work with the Council and Bristol to People's Forum on the Older People's Advisory Group to also try and make that more age-friendly as well and look at how we can embed our age-friendly goals and structure into that as well. So we know how that benefits older people going forward. And just lastly, before we bring this to a discussion, we just know, we want to just reiterate and stress the importance of where we are at this point, because we have worked for 6 years on this massive program across the city, and we have a year left. So we have the time dedicated to this, and we're all passionate about making sure that we actually get our learning across, embed that into the city, work across the sectors, work with different partners. And we know now from our learning how much of that was key, because we had the core team that had the capacity to build up the relationships, work with Sirona, work with the council, work with Bristol People's Forum, now like working with the Funding Alliance. So it was key that we were able to do that, but we also want to make sure that this legacy lasts and that we can continue this age-friendly work long after the Bristol Aging Better core program is gone. So that's why we're here today, and thank you so much for hearing us out about this. I'll now stop sharing my screen and we can move on to a discussion.
Brilliant, thanks Carly. And yeah, if you can take the screen down so we can see everybody again, that's good. Kay, do you want to say anything at this point, or shall we start the discussion and then you come in?
Yeah, just go through to discussion and I'll join in as when I can. Thanks.
Okay, thank you very much. I mean, I'm really passionate about this this whole project. I've been along to a lot of your events, and I think the rigor of it, by having the academic research that's been gone alongside it, really means that we can, and the city should, embed it. Asha and I were at an LGA webinar this morning about mental health, well-being and isolation, and I can't get out of my head one of the bits on one of the slides that we saw this morning. It was about, oh, and I should tell you that our own Victoria Blezard presented about the work that BNSSG has done on this, but it was about Barnsley Council, which did a day in the life one day in November and tried to capture photographs and people's views about what the pandemic was like. And one woman who was aged 72 said, "It's not really been any different for me because I never go out and I never speak to anybody. So welcome to my world to everybody else." And that isn't one woman in her 70s in Barnsley who's the only person who's experienced that, is it? We really know that has been, that is endemic really in our society. So I think that, the lessons from pieces of work like the Barnsley one, are really, it's great to share them. And it's great, as I say, that Victoria was there at that meeting this morning sharing what Bristol has done, which obviously isn't exclusively about older people, but we know that an age-friendly city will be a better city for everybody as well. So who wants to come in first? Asha, I know that you might have to leave us early, so do you want to speak now and then Elaine?
No, I'm actually fine, but
well, you've got what they call an old hand up then. So,
oh, have I? Apologies. Okay, let me get it down. Sorry, I have got an old hand.
Elaine.
Yeah, yes. I mean, as Wellbeing Settlement, we were part of some of the projects, but I won't speak about that because that's too sort of that's too much really. But just to say, I mean, just from my awareness of other projects, I just think they're just incredibly fantastic examples of innovative ways of working with older people. I'm particularly thinking about the work that Oasis Talk did with the BME elders and bringing forward people from within communities and training them as sort of as peers and supporting them as peers. I mean, those sorts of models, I think, are just really, really important when we're looking at sort of the future and we're looking at how we involve communities in their own health. I just think that we really mustn't lose those models, and it's really crucially important that we embed them into our future thinking, particularly around the community mental health framework. But that sort of learning actually applies to so many areas of the city's work. So I just wanted to mention that one in particular because I do think it was a terrific piece of work.
Thanks, Elaine. Janet.
Thank you. Carly, thanks for the presentation. Did I understand the slide where you had the interventions and then I can't remember if they were green or they were ticked in some way. Was that intended to indicate those interventions which had greater success than others? because the ones that appeared to jump out were community development, community navigation, and the Oasis talking therapies had a lot of what looked like green. And I just wondered, are we feeding that data in, just thinking of the links into things like building healthier communities and the work on social prescribing, to make sure that we grow the things that have got some kind of efficacy proven behind them?
Yeah, and that's a good question. Oh, sorry, can everybody hear me or no? I think I've gone. I don't know. Oh, can you hear me now? Okay. Sorry, this always happens when I start talking. Sorry about this. But yes, that's a good question. So in that table, because yes, the green were the statistically significant results, but it's actually kind of misleading because even on the right-hand side, you would see the BME well-being that Elaine just mentioned, and there was only one green square. But that's an example of where the green square was actually, so where we had a really good result was under the health of the participants, but other ones that weren't green were looking at, you know, more social contact with family and friends. But actually that whole program was actually just intended to try and improve health and well-being of people, looking at stress management, anxiety, sleep. So it's an incredible program. And actually, even though there's only one green box, to us, that was such an achievement. And again, that is a very sustainable and replicable project that we want to be able to scale up. And yes, we are definitely taking all of this learning because we have so many of these specific examples of where certain models have worked and certain models haven't worked as well. And we are taking that learning to the Healthier Communities delivery group, because Kay sits on that group and is able to share that back. And we're also now looking at presenting to the board as well in April with a lot of these models and examples of what has worked and what we're recommending for the future. And we also go to the Funding Alliance to recommend future funding for them as well, based on what has worked and what hasn't. So we are having those conversations.
Thank you.
Anybody else? I think it's also about, you know, the ticks in the boxes are sometimes the unexpected consequences, really, aren't they? You know, I think it was early on when I first had the adult social care portfolio that I was made aware of that ulcer clinic at the Withywood Centre, and fantastic that all of those things about bringing together the nurses from the surgeries and from BCH as it was still at the time, but also the social improvement for the people whose lives they weren't sitting at home waiting for their leg to be dressed and thinking that they were the only person in that awful position. They met other people. Because the Withywood Centre, in better times, obviously, has a cafe. They say, well, why don't we stay and have lunch together? All of those things just came from that one project, which was just wonderful to find those other outcomes, really. Alison.
Thank you. I can't see how to put my hand up in the other electronic sense. I think it's thank you, Carly, and it's clearly important. And you said you've got another year, and then you want to work out how we can continue, or work out what is best to continue. And as Elaine just mentioned, we've now all practices via their PCNs have got access to social prescribing link workers. And those people are going to be a really important resource to continue to be able to support people who are experiencing loneliness and isolation, aren't they? And also, as we've also said, we're developing the community mental health framework, and that will be another area where this should be factored in or considered where it's going to sit with people that are working there. So there's opportunity, isn't there, to overlap over the next year as a new spec is developed for that.
Zara.
Yes, thank you, Carly, for your great presentation. And isolation, it's something real. And where I work at the Somali Research Center, we help we work with a lot of mainly all the adults who are experiencing loneliness and isolation, and particularly those from Somali background. So I was wondering, what's your workforce representation like for those English is not first language, particularly, all the adults, it is, difficult for them to, if they are not speaking already, English, it will be very difficult for them to engage, with a worker, from your organization or from any other organization, if they cannot have someone to communicate with the same language. So what's your workforce representation like, in the city who speaks in many languages and, with different backgrounds? So that's my question.
Yeah, definitely. One of, oh no, I don't think you can hear me again right now. Can you hear me or no?
Can't hear you.
Oh, I'm so sorry. This keeps happening. I think, oh, can you hear me now? Okay. Yeah, so actually because yes, like you've just said, I mean, language is a massive barrier to participation in any type of service across the city. And that's why we think one of the strengths of the BAB program was we weren't running all the projects ourselves, but it was organizations, local organizations in the community who had access to local workers who were able to speak different languages. So we were actually engaged with a lot of different populations across Bristol in multiple different languages. And we were able to get translations of all of our information, of all of our questionnaires. So we actually did capture a fair representation of the city in our questionnaires. I know it's probably not as perfect as it could have been, but we did have kind of that local organization representing the communities and engaging with different populations. And Oasis Talking Therapies was one of the examples where they actually had 10 partner organizations in their project alone. So working across so many different organizations in the community. So I think that was a strength because, yeah, like you said, we couldn't do that. And if we can't speak different languages, then there's a massive barrier right there from the get-go. But we did have that strength of being able to fund different partners and local organizations in the city to help enable that we were working with as many people as we could really across the city. So we tried our best with that. Obviously, we weren't perfect. We still have most of the people who filled out our questionnaires were English speaking. But we did have access to the translations, and now we're not running any of our projects anymore, so that has stopped. So I don't have any more up-to-date information, but just what we did in the past, really.
Thank you. Tim.
Hi, thanks. Really interesting presentation, and the paper that was shared is fantastic. The results look amazing, I have to say, for this sort of project, and really has been done well. I was at a workshop this morning about population health management, which is an initiative that the CCG and our emerging ICS is pushing for, and the parallels with this work that you've done, and that just struck me. I think there's some benefit probably of thinking how we can use the sort of population health management data sharing and to get a better understanding of how we can design even better services for this sort of population and build on the evidence that you've already got. So I just wanted to flag that up.
Thanks very much. And in Carly, you mentioned about the meeting that you've got with Andrea coming up, and Raquel is here from the One City office as well. And so that ask about making sure that the needs of older people are reflected in the One City plan and in the structures has already gone, right up to Marvin's level. And I know that he wants us to find ways of making that happen. So thank you very much. Kay, do you want to just say anything just to round it off, and then because we're way behind timetable, I'm really sorry, but
thank you very much for your time. And I just a couple of things really, just put it together to say, obviously we've been through seismic change in the last year since that program, the 6-year program, but the learning is still relevant, and even more so. So we really do want this to be part of Build Back Better for Bristol. We've got huge amounts of learning there about the need for interventions across the spectrum of prevention and early intervention, not just one part, about the need for a whole system approach, the importance of co-production and of working in partnership. And some of the benefits of this are not just those individual projects. It is about the partnership working. We've seen some of the fruits of that since the pandemic, because a number of organisations in the voluntary sector who work with older people or who are formed of older people have come together to form the support hub. And I think that's in large part because we've learned to work together so collaboratively through the Bristol Aging Better programme. So I think it's that kind of approach, the learning from the approach, that I'd like us to take away as well. And if we can have a champion, if the programme is championed through the Health and Wellbeing Board, I feel that it gives us the structure and the core in order to build on the learning that we've had so far and make sure that those achievements aren't sort of lost to Bristol in a year's time. But thank you very much for listening, and thank you for your comments.
Thank you. And I think, you know, obviously we can't speak for the board going forward into the new administration, but I can't imagine that anybody would think it wasn't a good idea. And also I think that, you know, we are going to have to rethink our role in view of the changes in the NHS with the ICS coming in and the locality structure. And I think thinking about how we, you know, face that challenge and work with partners to make sure that we're as strong as we possibly can be through that next period is a really important message for us to take forward. But thanks both of you, and thanks to BAB and Age UK and all the multiplicity of other organisations that have worked with you on the project. It's been great. So we'll move very quickly on to the Bristol Health Partners Academic Health Science Centre, and David and Lisa and Olly who are here, I hope that in a way that's contextualised what you're going to talk to us about by being in on one of our other discussions. So over to you. Is it David, you first?
It is, and thank you very much for inviting us. Oliver Watson is the Joint Chief Operating Officer. Lisa is unavailable today. So we've got a short presentation. You've already seen the document, the summary we've sent you. So I'll be reasonably brief, and that way that leaves a little bit more time for questions. Olly, can you share the screen, please? Thank you. So if you could move to the first slide. So Bristol Health Partners has been in existence since 2012, and then it seems like a little bit more than a year ago, just before the lockdown occurred, we were designated by competitive process as one of the 8 UK academic health science centres, along with Oxford, London, Cambridge, Manchester and Newcastle. We have expanded the membership to include South Gloucester and North Somerset local authorities and Sirona, as well as the core members of the 2 acute trusts, the 2 universities, the CCG and Bristol City Council. We are really focused around delivering equitable multidisciplinary care through our partnership. Our main focus really is to try and address the knotty cross-system issues that don't fit neatly into one organisation or into one box. We bring together health professionals, patients, voluntary organisations, and researchers and commissioners under our health integration teams, which are very much bottom up to try and address some of these complex problems and to try and stop them falling between the cracks. And as you've just heard from BAB, to try and provide a very explicit and focused voice for some of these areas that maybe otherwise get lost. The board of Bristol Health Partners, which includes all of the chief operating officer, which includes the CEOs and the senior people, are very clear that we should have what we call the 3 pillars. That is a focus on inequalities in care, in children and young people, and mental health. We're not in any way saying that all of the other work we do isn't important, but particularly over the last year in the time of COVID, focusing our efforts where at all possible on those 3 areas we think is where there is the greatest need and where what resources we've got can be put to the very best use. We have our funding from our own partners and from the large-scale bids that we have participated in. Olly, could I have the next slide, please? What I've put up in the next slide is just a tiny percentage examples of some of the things that we've done over the last 8 or 9 years. I'm not going to go through them all, but suffice it to say that we have been actively involved in just about every aspect of chronic care, prevention, equitable care that's been going on across the entire partnership that includes Bristol, North Somerset, South Gloucester and its 1.1 million population. As I say, I'm not going to go through them, but you can see it's a very broad and eclectic mix of research and service redesign for the benefit of the patient population and our wider health and care community. Next slide, please, Olly. So what we've done here is really to map our 3 pillars, as I said earlier, mental health, inequality, and children and young adults, onto the One City plan. And it's not a coincidence that they overlap and really map onto each other completely. You can see on the left the priority areas for the One System plan and what we're able to bring to the party, so to speak. We work very closely with very many partners, and it's not a coincidence that BAB works closely with the dementia hit and the active older people hit. And similarly, the presentation you're about to hear next from Joe is very closely working and is part of, at least in part, the sexual health hit. So I think the point I want to make is that our role is not in any way to repeat or to conflict with any of the priorities of the individual members. We are to try and act as the glue that brings the various parties together and to particularly identify the gaps and to try and address them using our expertise and our academic excellence that we have at both of the universities in our cutting edge researchers. Last slide, please, Olly. So I think what Olly and I would very much like to hear from you is that whilst we are the vehicle for attracting investment and talent, and we can be fast and flexible, unlike many of the NHS organisations, we are not tied by national priorities or mountains of red tape. We can and do act very flexibly as new priorities come along, and never has that been more obvious than in the last year over COVID. And we particularly want to focus on health inequalities and injustice. So I guess the question we'd like to pose to you, and we're interested in discussing now, is how can we best support your health and wellbeing strategy? What more can we do? And then what challenge would you like to set us for the next 5 years? What real difference can we make? So I don't think I'll leave that slide up because I think it's more helpful for everyone to be able to see each other, but over to you.
Thank you very much, David and team. And I can see that Asha has got her hand up. So you first then, Asha, please.
Yeah, thanks. Yeah, thanks, David. And I've had the pleasure of seeing part of your presentation already. And I suppose if in terms of your ask and what do we want to see from you in the next 5 years. So as you know, for the Health and Wellbeing Board this year, one of our priorities is looking obviously at the impact of COVID, vaccinations, tackling health inequalities. And I'm thinking one of the issues that we're going to have is the long-term impact of COVID. And we're already seeing a lot of, even children are still feeling the effects of COVID. So I don't know if it's your place or maybe it's that, you know, because that's what you do, your partners, you can find ways and work with different partners, the university. And I know we want to do some more, a further review a year on, and hopefully the granular data that we're also that's going to come through in terms of number of cases, people taking up vaccines. But I think yeah, the longer term impact of COVID on the health of our citizens, what that looks like, how many, you know, who is it impacting on? Older people, you know, racialized communities, younger people. I think that's a piece of work that's definitely going to take 5 years, you know, over the next 5 years. That could be a really good piece of study or something that needs to be done for Bristol.
Thank you, and I couldn't agree more, Asha. I mean, having just had our annual funding round where we allocate resources to all of our health integration teams for the next year, starting in April, there was not a single one of our hits that did not have a major work stream on at least one aspect of COVID. And for many of them, almost their entire focus going forward over the next year is on post-COVID. Long COVID is one obvious area, but there are so many others. You know, all 5 of our mental health hits are focused on the terrible effects of the isolation, not just for adults and elderly people, but equally for children. I mean, the loss of learning, the loss of their isolation as well, you know, and particularly for disadvantaged children and for the adverse childhood experience hit. You know, it's to be quite frank, you know, every time I think about it, I almost I get very upset about it, because there is so much damage being done, and although there is quite a lot of lip service in the national press, the actual amount of effort and resource that is now being targeted at it is still woefully inadequate. I know in BNSSG, the STP and the CCG particularly, there's having a huge input of funding into mental health, but that's a great starting point, but then translating that through into the best evidence care, and where the evidence isn't there to generate the evidence, is something exactly as you say, Asha, that is going to take 3 to 5 years to do. Sadly, none of this is going to be a quick fix.
Can I just you know, so again, this morning, myself and Councillor Holland were at this LGA meeting, really good, and some really stark statistics about the cliff edge that we're about to also fall over in terms of mental health. They said they don't like calling it a cliff edge, but for me, it's a cliff edge. But some of the numbers, basically, based on the number of adults, I think they were saying that for each city, we're looking at potentially up to an additional 66,000 individuals who will be impacted with mental health through trauma, isolation, and 1.5 million children and young people across the UK. And obviously we have to take our fair share of that also. So, yeah.
Absolutely.
Okay, thank you.
Elaine.
Yeah, I was just interested about the sort of intersection between the work for the health partnership and the health partners and their capacity, and sort of what's emerging from the integrated care partnerships at a locality level, because we're obviously at a locality level, you know, I mean, and that's a great bringing together of everybody who have knowledge and intelligence around a locality and different perspectives. And I think we're still at a very early stage in terms of really understanding each other and really developing a true vision or a work program really for going forward. But I think that when we do get to that stage, I think there's some real opportunities for overlap with your work and with the hits, because, you know, I mean, you know, the localities in Bristol are very different. You know, they've got similarities, absolutely, but they also have absolutely their own flavour. And I think just again thinking about those responses that, you know, truly meet to the needs of communities and are really designed with communities and just have that subtleties, I think would be really interesting and is a real opportunity for the future.
Thank you. Yes, I again concur. It would be odd if I didn't. I think the comments I would make in response are, firstly, that, you know, the social deprivation, the inequalities are obviously inner city, rural and coastal, looking at BNSSG, each have their own needs and they are very different, exactly as you say. I mean, one of the points maybe I haven't sufficiently emphasized is that each of the hits is co-produced with the patients and public and members of the public. PPI and PPIE is absolutely integral, and you cannot become a hit or stay a hit unless you have that very strong patient voice and co-production. And I think that in terms of our work with the ICS, I mean, we obviously predated the ICS, and our remit of trying to pull everything together, find the cracks and fill them is obviously what ICSs are now about. So from our point of view, we're sitting slightly pretty and saying, well, we've been there and been doing that for a good while. But, you know, we are very, very keen to continue to be part of the ICS. I, as the director of BHP, already sit on the clinical cabinet, which is the main clinical decision body. We are seen very much as the route into the academic environment. But as we move forward with the new white paper, at the moment, I must say it surprises and, to be quite frank, disappoints me. There is no mention of research or evidence or value-based healthcare, which are all evidence-based, in the white paper. I think it's a major omission. We as the AHSC and others have fed back that point, but ICSs have their own flexibility. And I have already urged people like Robert and Julia to bring the health partnership in the AHSC and the universities into our ICS, because I think we have enormous value. And to put it the other way around, if they don't do it, then I think they are missing a voice.
David. Jarrett, that is.
Hi, David.
Hi, David. Hi. And David, thank you. And I was going to make a similar point to Elaine, so I'll just emphasise the point. David, I think it's great not only to engage you in the ICS, but in our ICPs in our localities, with that real focus on proactive, preventative healthcare supporting our communities. And I'm looking at your the 4 circles on my screen, on my other screen here, and the integrated, optimal and equitable care bubble really kind of sits firmly in there. And I'd be happy, David, let's take an action to pick up the phone after today and really think about how we do that.
Great, look forward to it, David.
Well, thank you very much. Oh, sorry, Christina, I missed you.
That's okay. It was just taking a cue from Dave Jarrett there. We have actually established within the system something called the Population Health, Health Inequality and Prevention Hub. And that is to try to bring together those 3 bits of activity and brain that were sitting rather unhelpfully separately in the previous incarnation of our system. And I think that David and Olly, is where to come and have that conversation. Peter Brindle is involved in that, as is Charlie, or Peter and Sarah are actually the project sponsors, I think is the name. But it would be great to bring it in there and make sure we've got a kind of rounded approach.
Thank you, Christina. And yes, we agree completely. We've been having conversations with both Peter and Sarah and Adwa about just that. We are ready, keen and very eager to input into it. Obviously, there's been a little bit of time to set it up. There were the original metrics that need to be done and populated, but that's largely out of the way. So yes, absolutely spot on. We're really keen to be part of that process.
Alison.
Very quickly, community mental health framework. You mentioned that, David, and I maybe I should have understood, but I'm not sure how closely there is a link there between your group, the Health Partners, and the development of the community mental health framework. But I think there certainly should be, and I think we would welcome a research focused look at how that strategy should be implemented, and also particularly how resources should be allocated if we're talking about trying to reduce inequalities.
Thank you, Alison. And yes, I agree. We're keen to be involved. I am aware of I'm sorry, I've forgotten the phrase you just used. I'm aware that it exists, but we don't know about as much about it as we should. I've taken the view that, you know, we should be doing outreach to everybody, and when people want us to involve us, we're really keen to do so. As I say, we have 5 health integration teams that are focused on mental health. Some of them are very definitely community focused. So I would like to think we have a significant role to play, but you know, we don't want to be seen to be too pushy and say to everyone, you've got to involve us. Obviously we have to be invited, but we'd love to be involved, Alison.
Could you put your email into the chat and then?
I'll ask Olly to do that because he'll be the point of contact.
Brilliant.
Oh, you're muted.
Sorry. Thank you very much indeed for that. And I think there's been a real synergy actually between the 2 last reports, hasn't there? Because the Bristol Aging Better and the Age Friendly City, the academic rigour that's been brought to that programme shows that, you know, those are the pointers that we as public agencies, when we're thinking about future funding and sustainability, those are all the things that we have to bear in mind. But having those assessments of the effectiveness of those programmes really helps us. So thank you for being here for that previous report as well as
you don't mind,
well as for your own.
We'd like to stay for Joe's as well, because obviously she's going to be presenting some stuff we're aware of as well.
Well, you're very welcome. I'm not really supposed to say that, but you will indulge you. That's fine.
Thank you.
Thank you very much, David and Oliver. So the last report, and I'm sorry that we're a bit behind time, but we have caught up a little bit, is the Fast Track City. And yes, Joanna, you're doing this one, aren't you?
Hi, yes, I am. Hi, everybody. I'm Jo Copping. I'm in consultant in public health. I'm just going to try and share my screen. Oops. Is that working? No.
No.
We've had some difficulties earlier on. Let's just try again. Yeah. Right, I will try another route.
Yep.
Yeah.
Yep, you can see that. Right. Okay. So I can't quite see the look that I was looking for, but I will. So if I'm turning my face to one side, I apologise. I've got 2 screens here. So so I can't actually see which slide necessarily that I'm presenting here, but hopefully I'll work through them all right. So as I said,
do you want to try to put it onto slideshow, because what we can see your
okay,
we can also
yep,
see your
that's
notes. Right.
So. Fine. Okay, yeah, that's does that work for everybody? Yeah. So yes, as David's mentioned, Fast Track Cities actually comes under the Bristol Health Partners, under the Sexual Health Improvement Programme. So I've come today really to let people know what we've been doing in the last 18 months. My colleague Mark McNally came in September, the 1.5 years ago, to ask the Health and Wellbeing Board to endorse Bristol to sign up as a Fast Track City. They agreed, and Marvin signed up at the very end of 2019. So just as a reminder, I've got a virus here that COVID is not the only virus to cause a pandemic, and HIV is actually responsible for 32 million deaths globally. So although HIV is rare, it does continue to be one of the most prevalent and deadliest pandemics worldwide. So what is Fast Track Cities? Most people will be aware that Fast Track Cities is a global initiative of which Bristol has signed up to. So within Bristol, it's a broad partnership of people, and you saw on that first slide that the 14 partners we have there, which are really there to accelerate our work to end HIV in Bristol. So why should HIV be a priority in 2021? I think obviously there's a lot of priorities within Bristol, and indeed people do argue sometimes that, you know, HIV, surely we've sorted that one already, but sadly we haven't. HIV deaths, although have decreased significantly as treatment has massively improved. However, we do have the tools to totally prevent HIV. through our education programs, through condoms, through testing for HIV, through pre-exposure and post-exposure prophylaxis, and through treatment that actually prevents people passing HIV on. So we've got the tools, however, we still haven't managed to end HIV. There are vast inequalities, as I'll come to a little bit, in HIV, and we know that early diagnosis is absolutely vital. And of course, we have made a pledge by signing up to be a fast-track city that we will end HIV. So in terms of just a little bit of the data, you can find this in our JSNA data profile. Bristol has a high prevalence of HIV. We're considered a high prevalence city, and our prevalence is actually significantly higher than England's. And as people live longer with HIV, as long as we continue to have new cases, that prevalence will continue to rise. We have around 900 people living with HIV in Bristol. But not all of them know it, and not all of them are on treatment, which means the virus continues to be passed on. So this is the number of new diagnoses in Bristol for people aged over 15. So you can see that it's not quite one a week, but we're still having, you know, significant numbers of new people being diagnosed within Bristol. This last chart here actually shows a bit of improvement, and I say that cautiously. So late diagnosis is much worse for everybody. It means that if people aren't diagnosed until later, they've got more chance to pass on the virus. They tend to be it's a much worse case for the patients if they're diagnosed later in terms of illness and in terms of death rates. And obviously costs for the NHS are much higher for people diagnosed late as well. We know that late diagnosis, although appears maybe to have improved recently, that it's still around 40% for Bristol. So that's still very, very high. And when we think of inequalities, this is a particular issue for Black African heterosexual men. When we look within Bristol, so this is our 2019 data, so we're aware of a number of inequalities which are fairly similar to the rest of the country. So HIV is related to deprivation. Our Black African communities are much more infected, as well as men who have sex with men. And you'll see this map highlighting that all of our localities or future ICPs are affected by HIV, although it's particularly an issue for the inner city. And as with everything, COVID has massively exacerbated these inequalities, especially amongst the more people with deprivation and HIV, and especially amongst some of the BME communities. So in terms of our fast track city work, as I say, we signed up to be a fast track city at the very end of 2019. We come under Bristol Health Partnership HIT, and we're also under Bristol One City. So we have goals within the One City plan as well. So therefore we come under the Health and Wellbeing Board. We also report to the Global Fast Track City Programme. We have recently developed 3 work streams to take forward our action plan. Those are testing, stigma, and that leadership programme. And our action plan has been very much driven by our HIV needs assessment, which was published in 2020. We're just coming to the end of our first year of action plan, and we're just looking at our next year. We have members of the public on all of our groups. So this is just to remind people that we are in the Bristol One City plan, and these are the targets that we've agreed to here, which fit with our Fast Track Cities global targets as well. So it's very much about ending HIV, improving treatment, and reducing stigma by 2030. We're also, within the Health and Wellbeing Board strategy, there are a number of priorities, but we have sexual health in there, and we'll put HIV alongside that one. So what has Fast Track Cities done in its last year or so of working? So we've signed the pledge, we've published the needs assessment, In March of last year, just as COVID was hitting, we had the National HIV Commission come to visit Bristol. They're aware of some of the good work that we were doing. We had Gareth Thomas, the rugby player, come along. He was part of a group of commissioners, and we took them round our voluntary sector organisations and our NHS organisations, including the Unity and the Brecon unit at North Bristol Trust. And they were taken on a tour, and we had a big consultation event about what people felt they should be recommending to the government about ending HIV. We were one of 5 places they visited. We've developed the action plan, as I mentioned. We have a website. We were one of the first cities, I think we were the 2nd city in the country to develop a new PrEP service, so it's pre-exposure prophylaxis service. So this is giving people treatment, people who are at high risk of developing HIV, giving them treatment to prevent it. We've had a big campaign run by Bristol, which was called Undetectable to Me, because we know that if the virus is undetectable on a blood test, that people can't transmit HIV. We were due to host the national conference, Fast Track Cities. Unfortunately, that had to be done online, but they will be hopefully coming to Bristol later this year. And we launched our one of our flagship services called Common Ambition Bristol. We launched that last month. So just a little bit about Common Ambition Bristol. We've heard lots about co-production, and I would like to say Common Ambition is trying to be co-production plus. So it's very much about the sharing power with people of African and Caribbean heritage to try and address our HIV inequalities. So the Fast Track City partners have joined up with African Voices Forum, and we are in the process of recruiting community members who will be very much working alongside our health services to see how we can encourage people from these communities to take up HIV testing, and how we can reduce inequalities and reduce stigma. And we also hope that it will have a knock-on effect of improving uptake of our sexual health services. So this does have wider implications for other services. So although it's particularly HIV stroke sexual health that we're looking at for Common Ambition, we hope that some of the findings of this project, which have been funded by the Health Foundation, will be replicable elsewhere into other areas. And just to say, the university is involved in formal evaluation of the programme. So we're really excited about this project, which is literally just launched. So what's on the horizon for HIV, apart from Common Ambition, as I say? The National HIV Commission presented its report in December of 2020, and the government have committed to ending HIV, ending new transmissions by 2030, which is only 9 years away. And we are expecting a national HIV plan this year. We're expecting the plan to reflect what was found in the HIV Commission report, which is very much about normalising HIV testing. At the moment, it's very much opt-in to testing rather than opting out, unless it's through antenatal care, which has been highly successful. The other big push is around reducing stigma, which is very prevalent still, especially amongst some communities. We will be required to develop a local plan for Bristol. I'd like to think that we are ahead of the game on that one. In terms of challenges, keeping HIV a priority is a challenge. There are many very important health issues for Bristol, and HIV for some may be seen as a smaller or one that we've already addressed to a certain extent. There's persistent stigma, inequalities are rife. The commissioning and funding, or commissioning of HIV prevention and treatment are complex, and how this will work going forward within the ICS, it's still not clear. And I think, yeah, one of the biggest challenges, we've committed to getting to 0 new cases by 2030, and I would definitely say that last mile will be the hardest. So in terms of our draft action plan for the following year, this hasn't, we've had another workshop to look at what we think should be taken forward to next year. I mean, there's been a load of activity this year. I mean, this is despite COVID, which has obviously had a big disruptive effect. The testing work stream are very keen to for us to be doing what NICE say that we should be doing, which is testing in our emergency department and testing in primary care, as well as exploring outreach options and exploring putting testing machines throughout the city. The stigma work stream are very keen to engage much better with primary care colleagues to help reduce stigma around HIV. They're keen to start measuring stigma through a survey, and also to work with our broader workplaces. And our system leadership group, which still covers everything, will obviously be leading the Common Ambition programme. There was a real push to promoting HIV amongst primary care, not just GPs, but pharmacies as well, and other primary care organisations, and also to consider more intensive support. We know there's a fair number of people who still are diagnosed but not engaging in treatment, and therefore still able to pass HIV on. These people tend to be the more vulnerable patients that we have in the community. So in terms of what can the Health and Wellbeing Board do? So yeah, the questions I've given to you today are really, how can you help us address those barriers, getting to zero new cases? How can you help address stigma within your own organisation? And how can you help us navigate the emerging ICSs and ICPs? In terms of comments on the action plan, I've only given you a few highlights from the action plan because it hasn't gone back through our work streams. But I'd like to hear from anything that you think should be in the action plan. It might, or of course, already be in there. And in terms of Common Ambition, for people to be aware of that programme of co-production, and to maybe understand what the wider implications could be for our health community. I'm going to stop sharing now.
Thanks.
Thank you.
Thanks very much, Jo. And it's unfortunate that Ash has had to go, because I know that he's the champion for this work.
Yes,
and you know, the commitment that the Mayor and Asha have shown to the goals, and making sure that Bristol is in this programme has been, you know, a driver, definitely, hasn't it?
Absolutely, yeah, absolutely. Yeah.
Anybody want to comment on what we've seen? I mean, I think that we're going to need a deeper conversation, actually, aren't we, about how the Health and Wellbeing Board, and perhaps it's a topic for a future one of our informal meetings, so that we can really.
Yes, I think the idea would be for it to really come to a development session, but it was just basically because we hadn't been here for for 18 months to really give you an idea of what progress has been made.
Yeah, no, that's been good. Thank you very much. Anybody? I can't see any hands, either virtual or real. Oh, Vicky, is that you, or are you just? No. Sorry, David.
Thanks, Jo. Great presentation. And your question around supporting navigating ICP. I'll refer back to the previous conversation. David, do the hits do all the hits come together at some point?
Yes, it's called the annual conference.
Ah, okay. Well, I'm just wondering whether we might. I don't know, whether we might do a session at that in terms of enabling and supporting all of them in understanding and navigating the new world order.
I think that's an outstanding idea, Dave, and it's incredibly topical, since we spent an hour and a half this morning at the Bristol Health Partners Executive discussing the content and the format for our annual conference. So Olly's still on the call, so let's take that offline, but I think that's a superb idea.
Okay.
Okay, great. Well, thank you very much, Jo, for the report, and it will be an ongoing conversation, won't it?
Thank you.
That brings us to the end of all of the formal report. So just before everybody goes, because I know we're a little bit over time, I need to tell you, in case you don't know, that for 2 people sitting around the table, the virtual table, it's their last meeting of the Health and Wellbeing Board, and that's Elaine and Alison. And I'm just going to say a few words about both of you, if that's all right. So Elaine, I think I've known you for about 100 years in various different guises, but I do think that the amazing thing that you've done at Wellspring, it's really putting our policies into action, isn't it, about what we really mean about co-production and the involvement of community in the wider health agenda. And it's been brilliant that you've been here as the VOSCA rep, yes, but with all of that background knowledge of what you've been doing at Wellspring, and we will certainly miss you. And so tell VOSCA that they've got to come up with at least, you know, somebody who knows at least 1/10 of what you know, or 3 people to cover all of those bases. It's been great to have you here, and so a big round of applause first to Elaine.
Thank you very much.
And Alison, what can I say? I do think, I mean, it's funny, we'll let you into a secret, the rest of you sitting with the board, is that, and Raquel, pretend that you didn't hear this, but we got a bit of pushback last week about whether or not the Health and Wellbeing Board could have 2 people presenting our priority. But I did push back and say, no, this is a genuine partnership. And although Alison, you couldn't be there, we still wanted to have both the Health and City Council partners who chair the board represented at that, and to give a very visible sign to the people gathered there. And I think there was about 350 people, that this is a real partnership. And I think it's been great to work with you personally. I've really, really enjoyed it. I'm often reminded of a program that the LGA, and I think it's NHS Improvement, have a joint program which is called When Worlds Collide, and I think it's a great name actually for because we're kind of from 2 different planets, and we both definitely have a different language and different 3-letter acronyms. But I think that what we've shown in Bristol by that co-chairing is that it's a really, really strong partnership with the NHS, and what you've brought us as a practicing GP, particularly in the last year, has been invaluable. So thank you both, but thank you, Alison. So a round of applause for
Thank you.
Alison.
Thank you.
Shall we embarrass you by asking you to respond to these, or does anybody else want to say anything?
I just go on, Elaine.
No, I'm just going to respond to say it's been a real pleasure working with you, and I really think in the time I've been on the board, actually that real sense of joint working's really come together, particularly through the development sessions. I think that, I mean, that build of sort of an understanding, mutual trust, openness, I think is really built through the development sessions, and I think they're a great way forward to really be able to work as individuals and to bring the understanding of perspectives, you know, to the extent that, you know, I really do trust you lot going forward in terms of really, you know, really bringing forward that personalised care that we all want, the integrated care that puts communities at the core of everything. So, you know, I trust you with that going forward, and I shall tell the next VOSCA rep that they've got to hold you to it. So, and a big thank you for some very beautiful flowers that arrived today, which was a lovely thought. So thank you very much indeed. Lovely working with you. Good luck. Good luck.
It's our absolute pleasure. Alison.
Yes, or to echo Elaine, really, I have found it a challenge and learnt a lot, actually, because I had my own world, which was general practice, and I've learnt a lot, and I think I've learnt a lot about how the council works, and I think it is really important that we have those 2 faces sat at the board. It's the whole point, and it's the point of the ICS as well. Let's not forget. But I think I'm reassured, Dave tells me that there will still be general practice representation, just in a slightly different way, possibly with 2 or 3 people sharing that role. So you will get 3 heads or 2 heads, so that's good. I will be working on the community mental health framework. So I therefore may see some of you in the future with that hat on, I guess. But thank you all. Thank you for all your support and help. I'd like to thank particularly actually Mark Allen, who really supported me, and Christina and Sally and Asha and Helen, obviously. Thank you.
Thank you. Dave, is yours an old hand? Do you want to? Are you about to make a speech?
I wasn't, but I can. I was going to write a note to say, I mean, both of you have offered, you know, amazing contributions to the board, and that you'll be deeply missed by us. But thank you so much for your contributions, and it's been great working with you.
Well, thank you very much, everybody. And on that note, I think we can close the meeting, but thank you for sticking with it. Sorry we had to lose Asha, but it's been a very, very interesting meeting once again. And subject to little local matters, hopefully we'll see you on the other side of the May elections. There is obviously the development session before that, isn't there? So thank you very much.
Thank you.